There's been a lot of discussion today, a lot of reservations that have been raised. How will this work? Will this work? And Keith and Michael, you did a great job of really simplifying, how we sort out the policy management. What we thought we'd do now is, I could go through a deck and bore you all to tears, but this will come out. Michael will be sending it out with all the other materials. So there's potentially some useful information in here. Maybe a little bit about us, but Keith, you were up earlier, sure. And so now you get to meet me. A little bit about Itiliti. Maybe if you want to do a quick 2 minutes on the history of Itiliti, maybe even 30 seconds. How about that?
Yeah, we started with Blue Cross Blue Shield Minnesota. We come from the payer world. We're building a platform that solves these problems for payers, and we feel like we have a good understanding of what you're trying to do.
Excellent. And for us, our work came out of CMS Blue Button. We got together with Microsoft, built our platform, and have made that available to both payers and Medicaid state agencies. So enough about us. We're really going to show how the two of us work together. And if you paid attention to your session earlier, there was an interesting case study in there. And what happens is we're actually jointly in the middle of implementing. And so what we really want to do is to go through and talk about really prior auth, but show you, right? So we're going to have you put on the hat of a provider, and we'll take you through doing a prior auth. And it will tie into everything that Itiliti talked about earlier. And ultimately, all of that data flows back into what I term the access APIs. So under the 57 rule, we have the patient access API is being expanded. A provider access API will be available so that a provider can pull down data about members from the plan. And obviously we are fickle beings, and so we move from plan to plan, so we're able to take our data with us when we go to a new plan, say, hey, here's my information, go get it, and pull all of that information forward. Well, that is, under the new rule, is going to include those prior auth decisions and all the supporting clinical data. So if you're a payer, there's going to be vast amount more clinical data because you tend to be asking for it as part of a prior auth, okay? So we get asked lots of questions. I'm actually going to, I think, stop there and let us see if I can quickly pull up.
Yeah, you can jump right in.
Why don't we go into the demo? So instead of talking about this, we're going to try and show you how it might work. So I have to say one thing. At Onyx, we basically produce APIs that are compliant with the regulations. It's really tough to show how that works because watching APIs is a bit like watching paint dry, right? So we created a smart app to basically act as the front end for a provider. Now, we're not really selling this. The last thing I want any payer to do is think, I'm going to create my own smart app. And so all you end up doing is moving your provider portal down into the provider's workflow and frustrating them to hell, right? They should be choosing the way that they are going to handle requesting a prior auth and then receiving information about that, and have one way of doing it regardless of which plan they're talking to, right? So we're showing you this as just a representation of what may happen. So I am first going to have a quick prayer to the demo gods, because you need to do that. Let them be friendly. And I am going to log in as a provider. And so I'm just going to authorize this smart app. And it is talking to basically an EMR. We have a Fire API behind the scenes that has got information about basically the patients. So, and Keith, feel free to jump in as we go through this if there's
Yeah, I
anything
want to highlight
relevant.
one thing you did just say, which is that we want the provider to be working in their EHR. We're pretending to be the EHR right now.
Yep.
And we want them to have one way to do this for every single payer in the world.
Yep.
That's the goal for January 1st, 2027. And the way that they're going to do that is with the help of QHINs, with the help of their EHR vendor, with the help of their interoperability platforms, all along the way, speaking the same language.
Great. So now that could be the EMR could be doing that, providing that built into the EMR platform. It could be a smart app provided by their QHIN. And again, they have one way of requesting to any payer. So let's actually try a prior auth. So I've pulled up the information straight out of the EMR. I'm going to choose the same provider. So we can do that. I'm going to pick out a health plan. Let's be the cool health plan because this is pretty cool, hopefully.
And importantly, these are all of the ingredients for building a CRD request. We know who the patient is. We know who the provider is. We might even know where it's going to be performed, like you mentioned earlier.
Yep. So we're basically putting all of this information together and let's do a service request, okay? So we're going to do that. And what we're actually going to do here in testing is I'm going to choose a particular code that is actually going to need to go to Itiliti. So I'm going to choose this. This is a weird procedure that you would have to do, which is called an Itiliti auth needed, but you can imagine that it's something else.
I think this procedure code's for a blepharoplasty.
Yeah.
Something along those lines.
Yeah. And so, okay, we're doing this and we can now go, let's review this. So we could go back in and say, okay, yeah, this all looks good. Let's submit this. So we're now sending this CRD request, like if we use the right terminology for the right bit of the various IGs. So we've sent over a prior authorization request and it's come back. Now, if my EMR let me write that data to the EMR on the results so far, I could do that. But now we can actually go into, there's a questionnaire required. So now we're getting into DTR.
Yeah. So we talked about on our presentation how a policy can have multiple things that it might need to satisfy that prior authorization submission. We're going to dig into down here. One of the most important, relevant to folks talking today is the questionnaire resource. So we can say there is a questionnaire here that will help guide you through what the requirements are for building that prior authorization submission. And go ahead.
Yeah. So what I'm doing, the questionnaire is basically come back. I'm now just connecting into effectively the EMR, where it's going to now take that questionnaire and the associated CQL, the clinical quality language, and go and basically query the EMR, right? And so it's going to take the tailored set of questions that has come from Itiliti Health, and it's going to ask me to fill in some stuff. Now, you may think, well, that's not very much, but what's actually happened is there's a number of other fields that have actually been filled in, which have basically been taken from the EMR. So I've got some information to put in, like my weight. Don't look. It's not me, right? And we can now proceed and submit the prior auth, okay? So we basically taken data out of the EMR, so it's been pulled automatically, none of this copying and pasting, and we filled in any of the blanks that needed to be filled in. Now, I did say earlier, looking at APIs is a bit like watching paint dry. So this is the paint drying piece, in that what we've got here is the FHIR bundle of data that is everything that came from the prefetch, everything that came from the questionnaire, any of that supporting data, observations, conditions, it could be any of that.
It could be an attachment, or it could be an attachment or one of those documents that we said, please upload this thing. We can build that right into the questionnaire, and now it becomes part of the FHIR bundle for the utilization management system, the automatic authorization rules and Itiliti health to ingest and compute an answer from, or generate guidance if you're a delegated vendor, or if your utilization management system is going to make a decision, it can make that decision now because it's received every single thing that you marked as required. And the provider only had to fill in the one missing question because maybe the MA hasn't yet typed in the patient's weight.
Yeah. So there we go. Obviously, in the real world, you wouldn't be seeing this. This would be happening automatically. But for the purposes of a demonstration, we wanted to be able to show you, look what's happening behind the scenes. So we can actually then go and submit that. So now this is effectively, we've now gone from DTR, we've now gone into PAS. So this is the prior authorization support. So that bundle has gone off to the vendor, in this case, Itiliti, and you have basically processed that and I think decided that it was automatically approved.
Yeah, so we'll see the status is we have our request, our transaction ID. Obviously, you don't want to write that down by hand. The EHR is going to keep track of that GUID for you. And we have our outcome, and this prior authorization submission is complete. And with that status or request ID, we can go and monitor it to make sure that, if they requested additional information or it was in a pending status for some reason, over time, that same transaction ID will allow us to keep checking in and say, I don't need to call and ask, is my prior authorization approved? My EHR can let me know, yep, you're good to go, green.
Yep.
Go ahead and schedule that patient.
So that's one of the things that we provide in our Onyx platform is actually registering that subscription so that you get notified as the provider, or the provider organization, you get notified when the decision has actually been made, right? So again, we saw in HTI4 actually looking at things like subscriptions now becoming one of those core components alongside CDS hooks. So that's really an important step forward because we want to see that in the EMR, in the environment that the provider's working in. So again, it's less burdensome. You haven't got to keep going back and saying, have they approved something today? It's going to pop up basically effectively in an inbox, okay? So we've taken you through effectively the complete process. So provider able to, maybe with the patient there in the room, actually going and seeing whether a prior auth is required. In this case, it was. We could have given you a demo where we go through and say, no, one isn't required.
You're good to go.
You're good to go. In which case, if you are as a provider are actually trying to book in a patient for a procedure, knowing that you can immediately go to that while they are in the room or before they've left the office, you've got a much higher chance that they're actually going to go through with the procedure. I've seen stats that say if somebody basically walks out of the office without that decision, and you've got to get in touch with them and then try and schedule them for that procedure, about 50% of people never follow through. So, what is the implications there for, overall care and health outcomes? So I think that there were a couple of other things that we wanted to cover, Keith, if I remember rightly. Let me pull this back in. So we've demonstrated this process. It could have been Epic, could have been talking through a QHIN, comes into Onyx, we pass it off to Itiliti, they give us answers, we pass it back. But there were some other questions. One of the things we come up against particularly, and maybe we can have a discussion, maybe a bit contentious, shall we?
Sure.
Is why doesn't, for example, particularly when we're talking about vendors behind the scenes dealing with payers, integrating theirs, why not just carry on with the X12 transactions? So, I mean,
I've got an opinion.
Yeah.
X12 transactions are able to do what they do today, and we know that it's not doing enough. So we have to change, and we have to change in a way that meets the needs of both the providers and the payers. Payers want more structured data from the providers. The providers don't want to fill in any more paper forms or portal forms or electronic forms that require them to do anything that they've already typed into their EHR. So our goal is, very first thing to do, help them answer that simple question. Save them the hassle of having to say, well, go wait in the waiting room. We'll call your insurance and see if we need to submit any extra paperwork before we can get you scheduled. Now we can say, as soon as the doctor places the order, that order behind the scenes is going to go out, talk to the payer. The payer is going to immediately be able to generate an answer of, is prior authorization required? For some of our customers that are using this functionality today, especially like if they are putting it on their website, making it published, they're replacing phone calls, they're saving time in their call center, they're saving the provider's time in their back office. With this API, you don't even have to have the patient leave the room. They can see the answer, the provider can see the answer right there in the EHR.
And there's also some other benefits that come from all of this. Remember, under 0057, there's this need to make the data available within 1 business day effectively to both the patient, potentially to providers, and when we change plans at the end of the year, there's moving that data forward. And think about how that could work. If the data is coming out of the vendor, is being processed so it's available in FHIR format, so it's in the patient access API effectively within 1 business day. For those firewalls that maybe do take a little time to work through, I, as a patient, if my consumer app supports it, could be going in and checking what's the status. I could do that myself. Equally, if you think about the way things are evolving with value-based care, maybe as a provider, I had sent my patient off to a specialist and they have put in the prior auth. They get the answer back because that's the process. It's a handshake there. It's that conversation we've all been talking about.
And that's actually a really important use case. Is it's not just that there are 2 different providers. Many providers are working in 2 different systems between their home practice or their clinic and the hospital or medical center where that surgery is going to be performed. The great part about this is that that set of coverage plus patient plus procedure uniquely maps to that prior authorization for that service date. We know it's approved. Any system can come across the QHIN, across the national network, talk to the payer and say, oh yeah, they've got this prior authorization. Its status is approved. All the information has been filed. And now we're not faxing forms back and forth between a clinic and a medical center trying to get it scheduled.
Yeah. So I think we've hopefully shown you something interesting. Let's say we've tried to take this and show you, you can really do this, right? This is not just theory. We can actually make this work. There's lots of things that we have to solve still. One of the things we haven't really talked about today, we covered, I know, earlier this morning about provider networks. Well, we need payer networks as well to be able to find those endpoints. We've also got to address, how do you get connected to those secure APIs, whether you're a provider organization, whether you're another payer. The process that we have in place today, if we follow what was done with the patient access API and consumer apps, that is a totally non-scalable solution. It will not scale up to have thousands of providers trying to get a set of credentials off 900 payers. It's not even going to work for 900 payers to get credentials off the other 963 payers. We have to solve this problem, but it's solvable. The technology building blocks are there. It's whether we've got the incentive to go and do it together. So I think we've talked enough. Let's open it up for any questions. And I don't know if there's been anything on the chat. But does anybody have any questions about what they've seen today? Do I see we got someone in the back?
Hey, Emma from the AMA. Can you reiterate step 4, clinical assistant with AI? Is that where in this approach you're putting the clinical decision making?
Right, this is a feature that can supplement your utilization management system where you take and compute all of the data that was submitted as part of that prior authorization submission, and you compare it against your policies. You go and search for, all right, they uploaded a document. I need to find where that document meets this criteria. And AI is actually really good at that. It's not good at computing exact rules, but it is good at finding text that might match. That's about all you can trust it to do 100% of the time is text that might match, and then you let a human say, yes, this part of the submitted documentation satisfies this criteria, now we're good to go.
Okay, so are you putting step one then, is that triggered by order sign or
Yep,
like at
order
what?
sign.
Okay, so that
Order
would
sign
be
or
order
appointment
sign.
book are the most common triggers. You could also do things like order select if you're trying to help guide a provider to a medication that's covered or guide a provider to a specific imaging procedure that is, you need to do the x-ray before you do the MRI, that sort of thing. You can do that with order select as well.
Okay, got it. Yeah, I think from the provider perspective, we're generally advocating more for the order sign because we would want the treatment to be, dependent
Exactly.
on clinical
Right.
reasoning rather than, what's the coverage policy. Thank you.
Great questions. Thank you.
Okay. Someone at the back.
So I have a question about the cool plan. For that, like, what is the implementation on that? How long does it take? Because you got to think about it. Some of these payers, like you said, thousands of plans, products, all that. What does that look like?
Well, I think that's one of our big challenges as a community, because you are basically either effectively within your EMR or wherever it's implementing this capability to go out and ask a payer, is you're going to have a set of credentials to go knock on that door and be able to ask the question. And at the moment, I can tell you from having written some of the one of the IGs where we were dealing with that in provider access. It's the same basic challenge. How do you get connected? And the way that we've written it in the standard is to say you need to use basically the tools that we're using everywhere. We're basically saying smart on fire. You need to have a client ID and a secret, right? Now, how you get those, now you could go to the payer's portal and they may have a developer portal and you could go and request that. That's fine. You can do that. That will probably work for the first, 5 or 10 payers that you need to connect to. It's not going to scale. That's where we need to look at things like, and I'm a big proponent of fast security and the UDAP business to business capability. There's the tools are there to implement that so that you would what you would basically then do with that type of capability is there would be some sort of umbrella framework, let's say, that you would go and basically agree that you're going to follow the rules. Whatever those rules have been agreed about, we're going to do prior auth or we're going to do provider access. And you're going to agree that, yes, we'll abide by a common set of rules. And any other payers that join do the same thing, right? We all agree to work the same way. And as a result of that, you get issued a certificate that you can present. And we're talking standard, if we technically 509 certificate, just like you would have for your SSL cert on your website, basically. But you're then able to present that together with all of the information that you normally key in manually to a developer portal to get a client ID and secret. So it can be automated. But the advantage of having that certificate is the recipient, the payer, can actually check that it's still valid, right? So are you still playing by the rules? Have you've not been kicked out of the community? That capability, it's been there in OAuth for years. It's known as dynamic client registration. But nobody uses it because there wasn't a way of checking, is the person that's asking for these credentials legitimate? And really what UDAP has done is provide that level of legitimacy. What we have to do now as a community is basically say, let's agree that set of rules. Let's work out how you get issued with one of those certificates. Because that's the way, then what would happen is you would have, the first time would be, I can find out where I need to go, hence the directory, the endpoint directory. I can find that, and that tells me then how I apply for a credential. I present those credentials automatically, get that credential, and push it into my app or service, and away I go. This is not new technology. I, in fact, demonstrated it, I think, at Dev Days in 2017 as something that we were looking at in CMS Blue Button. But the technology is there if we want to use it, and we have to realize we need to use it.
And to give a very short version of that answer, the timeline for a provider to onboard a new payer or for a payer to allow a new provider to connect to them could be 5 seconds. It could be dynamic. You calculate a checksum on a certificate, you check it against a revocation list, and you're good to go. But that does require that you've stood up these APIs, that you've agreed with the rest of the community on who you want issuing those certificates. And that's really the call to action.
Okay. I think we're about to get the finish sign, yes? One last question?
Unless there are any questions from the audience, virtual and here in Chicago.
Okay, well, thank you, Keith. Thank you for the opportunity to demonstrate.
Thank you for the great
We showed
question.
you, this is real. We can do this. Let's go do it.
Thanks once again, Mark and Keith. Thanks to Onyx and Itiliti Health.